Good evening, everybody who's here already. My name is Libby Thomas. I am a reader in clinical education, actually, at Queen Mary's University in East London. So we're on the same site as Barts Health and the Royal London Hospital. I'm an emergency medicine consultant as well, down at King's College Hospital in South London. And I've been working in the higher education field for many years now. But I'm really lucky to work with an amazing group of people across the Emergency and Resuscitation Medicine MSc, which we run at Queen Mary's. And this is a distance online MSc for doctors, nurses, and paramedics from the UK and from all across the world. And it's run through asynchronous lectures and podcasts and content, as well as online face-to-face tutorials and assignments split over 3 years. So you can do it whilst working along a full-time job, which is what most people do. It's pretty full on. Tonight, we were meant to be joined by 2 speakers. Unfortunately, Harriet is laid up in bed with pneumonia, bless her, and feeling very sorry for herself. So we're very grateful for Johnny, who definitely is here tonight, and was doing this with Harriet, and he's now going to take it on his own, which is fantastic. Johnny and Harriet work together as EM trainees in London and across the HEMS world. And this is based on some work they presented last year at the USEM conference, which is currently going on in Belgium, I believe. And our leader, Tim Harris, is currently there at the moment as he organises the USEM conference. Can't be with us tonight because he's at a faculty dinner giving a speech there. Johnny is a consultant in emergency medicine at Leeds Teaching Hospital. He also works in HEMS for Links and Knots, and he also has a car-based job too, as well as having 2 small children, so not much on his plate. Thank you very much for coming tonight, Johnny, and I'm going to hand over to you. Just to say, if people want to ask any questions, pop them into the chat. I will be facilitating that. And the presentation will be about 25 minutes long, and then we'll have a Q&A afterwards. So do please stick around for that. But thank you, Johnny, and over to you.
Hi, good evening, everyone. Can everyone hear me? Can I have a wave if you can hear me? Good, and you should be able to see some slides. Thanks for having me here tonight. It's great to be here to talk to you. I previously taught on the ERM syllabus at QMUL and been around a lot of the trainees and seen people come all the way through the system. And I've got lots of colleagues now in the HEMS world who have their degrees and masters from there. So a valuable thing to get into. I'm sorry that Harriet isn't here. She's much more glamorous than me and much better spoken. So apologies if I'm a bit northern for some of you from Essex and probably a bit southern for some of you from further afield. I'll do my best with this. This, as Libby said, is part of a presentation that we gave at USEM in Copenhagen last year. And it really is just trying to emphasize the time-critical nature of penetrating trauma and bleeding. And it's something that you may have seen a lot of depending on where you work. It's something that you may have seen very much not any of depending on where you work. And unfortunately, penetrating trauma is really a disease of deprivation. And you will see it where people, unfortunately, don't have the privilege that they have in other parts of the world. We've seen plenty in London, and we're going to talk about 2 cases in London unfolding in something like real time during this presentation. So just my background, had a bit of a bio from me, but I'm an ED consultant and HEMS consultant. I also work for Yorkshire Ambulance Service for the Merit, which is kind of a critical care car, which has been set up recently. I haven't any conflicts to declare. Fortunately, Harriet isn't joining us. So I don't know whether any of you remember 24, probably most of you are too young, but the idea was that this is going to unfold in something like real time. And over the next 24 minutes, I'm going to take you through the journey of 2 patients in London. This is London, for those of you that don't recognise it. It looks somewhat familiar from the EastEnders theme tune. You can see the river running through the centre and roughly dividing it into north and south. And then these are all the different boroughs of London. So London has a daytime population of around about 10 million people. And of those 10 million people, about 6,000 times a day, they will call the ambulance service with a medical emergency. So a lot of calls, and maybe very different to where you work.
Johnny, we've just lost your slide.
Okay. Can you see anything at all now?
I can see you.
Okay. Let me stop sharing and try sharing again and see if it makes a difference.
Oh, you can see, other people can see the London map. Okay, that's fine. I've got some.
Okay.
There we go. Cool.
Yeah. Hopefully everyone can see that still.
Yeah.
So this is a map of London. We're going to focus on two boroughs, one in North London, Newham, which is where the yellow star is, and this is one of our patients, and the slides involving that patient will be colour-coded yellow. Newham is one of the most deprived areas in the whole of the UK, so a lot of social deprivation, and unfortunately somewhere you spend quite a lot of time if you're a HEMS doctor or a paramedic, I'm sure, in East London. And Croydon, likewise, a very deprived borough in South London, and again, a lot of penetrating trauma down there. And for those of you that live and work down there, that won't be a surprise to you. And again, the red star and the red coloration for the slides will correspond to our patient. So in North London, Danny is a 15-year-old male. A right-handed attacker stabs him with a knife once and flees the scene. He's bleeding, he's scared, and he drags himself to a nearby convenience store. Unfortunately, we are seeing something of an epidemic of pediatric stabbings, and it's more and more common. And what we know from some studies, this is one by Paul Villamy, who's also a previous QMUL alumni, who looked at pediatric trauma and found that there's a temporal association with school kicking out time. So rival gangs of kids bumping into each other at shops often then ended up getting to altercations, and unfortunately, more and more carrying bladed weapons as part of those altercations. What we found was there's a peak between 4 and 6 o'clock, often close to home on school days, of penetrating trauma. And this is something we'll talk a bit about later in how we might prevent some of this from happening. Down in South London, unfolding at exactly the same time, Idris is a 19-year-old and he's with his girlfriend when an altercation breaks out. There are fists flying, and he sees a knife and he runs from the scene. Again, just to put into context the amount of knife crime that we're seeing, we've had nearly a doubling, a 78% increase in recorded knifing events in the last 10 years in the UK. And that's changed a lot in the time that I've been doing emergency medicine. And where initially this was very much a London phenomenon, we're seeing this increasingly in cities outside of London, in Birmingham, in Leeds, Sheffield, and other big centres as well. So we're just 1 minute in now after the time of injury. Bleeding from his wound, Danny's slumped in the corner of the shop, and the owner places a call to police. This is something that we'll talk about later. Idris, on the other hand, he stops running about 200 meters from the scene. His right leg feels wet, it's heavy, and he can't run anymore. He looks down to see blood soaking through his clothes. This is actually something that we see really commonly. Often people don't know they've been stabbed. The catecholamine release that comes with your fight or flight response is very, very powerful, analgesic. And it's often that people don't realize until it's pointed out. I've had many patients who have explained just this, that they only realized there was a problem when they noticed that it were actually wet or could see the blood. And he decides to hide, and he calls his girlfriend from his mobile phone. Just 3 minutes after the time of injury, Idris's girlfriend arrives and sees him bleeding. She immediately calls for an ambulance. This is definitely one reason why men live longer when they've got women in their lives, because she does a very sensible thing. At 5 minutes, the police arrive with Danny. So the shop owners call the police. They see he's bleeding from a left upper thigh and groin wound, and an officer grabs a trauma kit from a response vehicle, and their colleague puts out an immediate call for ambulance support. We're seeing again increasingly that police provide a vital role in trauma care. They're often the first on scene to many of these events, partly because of security concerns. It's often the case that ambulances and healthcare providers need to stand off until the scene's been made safe, so the police are first in, but they're also often in the local area. And they all carry, certainly in London and lots of other areas, will carry a trauma kit, which will have urgent supplies with things like compression bandages, tourniquets, gloves and other bits. And with firearms police, they often have a slightly extended skills spectrum, so they actually have a higher level of training, but will carry airway kit and various other bits as well for advanced interventions, which is really important. And the police officer goes and grabs from the trauma kit a tourniquet. Tourniquets are absolutely life-saving for extremity trauma, and when they're placed at the right time and early enough, they can prevent people bleeding to death, and it's exactly the right thing to do. And I think we're going to see these increasingly commonly used in civilian practice. Just like we say AEDs in public places, we're going to increasingly see bleeding kits in public places as well, as a response to things like the Manchester bombing, where, again, immediate life-saving care wasn't available. And we're going to be teaching people how to put these on in civilian practice more and more. Back in South London, an ambulance is dispatched on a priority call. The girlfriend of Idris puts out some pressure on the wound. She notices that he's sweaty and he vomits a short time after arrival. I think hopefully we'll all recognise these patients and the look of being unwell. And it's something as a healthcare provider that you just instinctively recognise. So this is a poorly patient, somebody who's sweaty and vomiting, probably becoming a bit hypotensive and a bit vagal. And they're on a downwards trajectory, and that's really important to recognise. The most important thing that anyone could do in terms of a bystander or a non-medically trained person is put some pressure on the wound, and that is what he gets. And it's buying some vital minutes, which are going to really come into their own a little later in the job. So just again, a few minutes later, HEMS are activated by the paramedic in the EOC. So there's a big operation centre in Waterloo for London, and those 6,000 calls are screened by one paramedic. It's a pretty thankless task, and all quite manual, and they're listening into the call, and all they can hear in the background when they listen into the call that they've heard is a stabbing is screaming, and that's sometimes all that you get. And you're really reliant on your spidey sense as to whether you're going to send the HEMS team to one of the maybe 4 or 5 jobs that they're going to do in that 24 hours, whether this is one that gets a HEMS team. So that is a ration resource. And they make the decision on the information that they've had and what they can hear in the call to send the HEMS team. Fortunately, they're only 8 minutes away. They've just handed over at hospital and they're set up immediately. So 8 minutes in, both patients have ambulances now with them. So at exactly the same time, ambulances have arrived with both patients. They contain a paramedic and a technician, and they proceed to make a rapid assessment of the injuries of both patients. And this 8 minutes represents the mean average CAT1 time, CAT1 being for immediate response. These are things like cardiac arrest, unconscious trauma, life-threatening bleeding that give the highest priority for the ambulance service. And the mean response is about 8 minutes in the UK. And when they come in there, they're immediately struck by the amount of blood on the floor next to Danny. There's a very large red puddle that he's sitting in. He's pale. He's got a single wound, 2 inches distal to the groin crease on his leg. Whether you'd be familiar with your anatomy around the groin, but the groin crease is a very important marker because the groin crease tells you where the common femoral artery is, which is something that can cause you to bleed to death very quickly if that's been injured. There's a tourniquet proximal to that wound, it's just about possible to get a tourniquet there. It's tight and there's no bleeding. So they feel that there might be a degree of control. He doesn't look very well though. His breathing's deep, it's rapid, his pulse is 50, which I think you'd agree seems pretty inappropriate for somebody who's bleeding, and it's very thready. He's got no veins for IV access, and he's drowsy and less responsive. Everything that we are as human beings has evolved over millions of years to be what we are. And one of the things that we've evolved to do is to protect our brain at all costs. And so if your brain stops working, you become drowsy and you're not perfusing your brain, something very bad has happened. And again, if you can recognize that, it's very important. And they recognize these are some of the signs of exsanguinating hemorrhage. So there's a term that's been coined to look at those patients that are bleeding to death. If they don't have central control and immediate resuscitation, they will die. And the signs have been distilled in something called the Hateful Eight, which you may have heard of. So that's that patients are pale, they're clammy, they've got air hunger. That's that deep, rapid breathing, which you see in hypovolemia. They've got venous collapse, so they're very difficult to cannulate. They're hypotensive. They can have a very low or falling end-tidal CO2. They could be tachycardic or bradycardic in the case like this. So when you get to terminal bleeding and the heart starts to be hypoperfused, you often become bradycardic, and that's often a sign that's under-recognized. So inappropriate bradycardia, very serious, your patient's going to die. And they have altered mentation. I'll say that's the most serious thing. We've evolved over millions of years to look after our brain, and if you're not looking after your brain, it's because you're decompensating. Back in South London, Idris is supine on the floor. There's a trail of blood down the street from where he's run, and there's a wound approximately a third of the way down his thigh, which is oozing. He's tachycardic at 140 beats per minute, so very quick, and he tells the paramedics he is dying. Again, if you've ever been in this position, you should listen to the patient, and this should probably inject a little bit of pace into your job because they're often right. Patients do often have a sense of when they're becoming unwell, and one of the last things I've often heard from patients when they do die is that they are dying. So take that very seriously. The paramedics do exactly the right thing. They provide some direct pressure and control over the wound. So using a trauma bandage, which can provide tension through the elastic, and some targeted pressure using something like an Israeli dressing or an Oleus bandage. And again, these dressings can be life-saving if applied at the right time. That might be deployed in conjunction with something like Celox, so a clotting agent, which can be packed into the wound and help to stop bleeding. Again, really important to get that in early. Back in North London with Danny, the paramedics face a really difficult choice. They understand he's sick, and they know that short scene times in sick patients with penetrating trauma contribute to favourable outcomes. For every minute of scene time, your mortality is increased by 1%. So they need to get moving. So the definitive care for most trauma patients with penetrating trauma is diesel. It's about getting to hospital quickly, and they understand that. However, at 10 minutes, they also know that he's critically unwell. He's hypovolemic, and they're not sure that he's going to make it to hospital without some intervention. So they decide to stop and place an intraosseous needle in his right humerus They get a police officer to squeeze a bag and they haul Johnny onto a trolley and start to move. So they take that extra minute just to put something in to try and buy him some time. At the same time in South London, Idris's bleeding isn't controlled. The crew have attempted to cannulate and apply a tourniquet to his thigh. Again, we talked about tourniquets already, but again, extremely important, and for extremity trauma, absolutely life-saving. So again, the right thing to do. 12 minutes in, the team in North London scoop and run. The Royal London, which is the nearest major trauma centre, is just 8 minutes away, and they get on their way to do that. Again, we said diesel is what these patients need. At 14 minutes, they pre-alert the hospital, so they get in touch and the hospital declares a code red. So code red is a suite of interventions which was started at the Royal London to try and reduce mortality from traumatic bleeding. And these patients typically have got blood pressures less than 90 systolic, typically have got either external or internal significant hemorrhage. And the idea is that through a suite of interventions, you can get the whole hospital to have a response for this one patient. So they will stop a theatre and alert them. They will activate a massive transfusion protocol. They will also put into place senior care at the bedside. So you'll have a consultant delivered and led service for that patient when they arrive. And over time, that's seen massive improvements in mortality for this group of patients. So from 45% in 2008 to 27% in 2017, and with a stated aim of by the end of the decade, reducing that to 10%. So really incredible what can be done when a whole hospital pulls together for one patient. At 15 minutes, the HEMS team arrive with Idris. So he's unresponsive and the crew are very task focused with getting IV access. What you'll often see when you're not so stressed yourself and you walk into a room with very stressed people is that the stressed people have got a very narrow focus. And that's one of the things that happens when we are overwhelmed, physically, psychologically. When a heartbeat increases, you lose all of your motor skills, things become more difficult. You have to spend more time and attention doing them. And the crew have got stuck. They're trying to get IV access and fighting to do that and they can't. And they haven't also recognized that. And that's something that we see very commonly and something that's really important to be aware of when you're delivering trauma care. The doctor paramedic team assessing, they cut off his clothes and perform a stab check. Again, we said that many stabbing patients simply do not recognize when they've been injured. And if you have one injury, which is the one that's obvious and often the one that's bleeding, you might not notice the other one that's killing you. It's frequently the case that patients will have multiple stab wounds. Unless you identify them, you might be missing the thing that's actually killing the patient. Even a small wound over the chest in the right place, maybe even a few millimeters, might be enough to have penetrated through the chest wall into the pericardium and might be causing bleeding, and you'll die from your pericardial tamponade before you will from your exsanguination. So really important to have a look. So they don't take any chances, they cut everything off, have a really thorough stab check. And they task the crew with getting IO access, because IV has been proven to be pretty much impossible for the patient this time, and to put a second tourniquet on the leg because the bleeding's not controlled. And again, with large compartments, sometimes you will need to place a second tourniquet on there. The tourniquet is working by compressing all of that muscle against the bone usually. And on something like a thigh, there's a lot of muscle to compress. So a second tourniquet is sometimes required for you to be able to get vascular control. And that's what they get them to do. Idris at this time is peri-arrest. He's got no radial pulse. His carotid is just palpable. And again, he's not cerebrating. So again, if I can impress on you how important it is, if somebody is not fully conscious, they're not GCS 15 with bleeding, they're bleeding to death until proven otherwise. Really important to notice. So we're 18 minutes in. It's felt like a whirlwind already. And they decide to stay and play in South London. We talked about these two different paradigms, so scoop and run. So applying diesel, getting away from the scene as quickly as possible to hospital and definitive care. This is the second one, this is stay and play. And the team now with some extended skills and bringing the hospital to the patient are going to do a bit more. They're sticking some central access. So this is a MAC line. It's a big trauma line, 9 French. You can give 500 or 600 mils a minute of blood through this under pressure. So very quick. And the idea is that you can try and catch up on what's been lost and try and outpace the bleeding that's happening elsewhere to improve your hemodynamic state. And the typical place we'll put this is in the subclavian. And the reason for that is anatomically, it's triangular and it's splintered open in that position. So even in significant hypovolemia, you'll have a patent subclavian when you might have a completely collapsed internal jugular or a femoral. So it's one place that we can sometimes get access when you can't get access anywhere else. And it's extremely valuable to have this sort of access with bleeding patients. It can be the difference between life or death. So the team insert this access and start giving some blood. The blood they're giving is whole blood. So this is part of the SWIFT trial that was actually just recently concluded recruitment. But this is looking at giving whole blood. So it's a mix of your red cells, your red, your plasma, your yellow, and hopefully in the future is going to be platelets as well, which is essentially the best thing to give. If you've lost blood, which contains all those things, we should put all of that stuff back. And we're lucky enough that most of our pre-hospital care services in the UK carry blood, should be able to get that back. Back in North London then, the ambulance is accelerating away towards the Royal London. As it comes onto the main road, Danny's breathing becomes agonal. For those of you that spent some time in ambulances, you'll often see hemodynamic changes in response to the ambulance moving. Sounds crazy, but next time you're in the back of an ambulance, have a look if you've got a sick patient and see what happens to their heart rate as they accelerate, or if you're braking coming up to a roundabout. And what tends to happen is as you accelerate away with hypovolemic patients, with their head pointing towards the front of their cab, all the blood moves towards their feet. And when that happens, they reduce their venous return and you see an increase in the tachycardia, or if they're terminally hypovolemic, they become bradycardic and agonal. And then as you slow down coming into the roundabout, as you approach the junction, all the blood goes back towards the head, the heart starts to fill, and you see some resolution of that tachycardia or an improvement in the bradycardia. And that's telling you that somebody's right on the edge. So they're absolutely on the edge in terms of their volume status. And you will see that in these patients. And unfortunately for Danny, that proves to be the case. He's bradycardic and without a central pulse at this time. The crew know that those same effects that are happening that can also help them. So by lifting the legs, they can use gravity as a force to try and help them. So you can return a few hundred mils of blood from the legs and also mitigate some of this hemodynamic change of the ambulance by lifting the legs. So lifting the legs can give you a transient 8 to 10% increase in stroke volume. They're doing everything that they can to buy some time. 18 minutes in though, they start CPR. So at that time, they can't detect a pulse. They're not sure what else they can do. And Danny, they think, is dying and they start CPR. So the police officer and the paramedic in the back start CPR while they're still on their way to hospital. Back in South London, the HEMS team have got some other toys to play with and decide to deploy some of these. So they're going to insert a femoral arterial line, which allows some invasive arterial blood pressure monitoring. So that's the stuff on the left. And they're going to use ultrasound to do that, which is a standard of care for doing this. This is a butterfly probe. I don't know whether you've seen this, but technology is increasingly getting smaller and more capable. And this is something you can carry around and plug into a phone or an iPad, so it can be in your pocket. And access to that is really meaning that we can provide hospital standards of care, again, in the community, which is really valuable. The reason it's valuable is that 2 minutes later, they've got an invasive arterial blood pressure for the patient, so we can know an actual blood pressure. And what we know is that non-invasive BP is really, really unreliable in these patients. So you'll often see patients that are hypotensive and hypoperfused have unrecorded BPs. You'll very frequently see spurious BPs, often with a very high systolic and diastolic. So I had a patient yesterday who was bleeding to death from a stabbing that I was treating in Yorkshire. He had a blood pressure of 180 over 150. I didn't think that was real. And that's an artifact that you see with non-invasive blood pressure cuffs at the extremes of physiology, when he was actually bleeding to death and had no radial pulse and was barely conscious. So invasive arterial BP, really important in terms of monitoring and treating these patients. At the same time, Danny's arriving in the ED, so having made the decision to leave earlier, they're now at hospital. He's been in arrest for 5 minutes and his rhythm is a Borg complex PEA. So we're just 22 minutes at the time of injury. The team at the Royal London are already prepared to do a thoracotomy. This is a Finicchietto spreader. This is what we use to do a thoracotomy, to spread the sternum so that it can get access to the heart. They will have also read this paper by Wise probably several times in the run up to doing this, and maybe done lots of thoracotomies, because unfortunately the Royal London is one of those places that does. What they might not have known, and this QR code will give you a link to a paper that was released today by JAMA Surgery from a group at the Royal London, the London's Air Ambulance, was that patients that are bleeding to death don't have a very big survivable window. So what we've learned from a case series of 601 patients treated at London's Air Ambulance is that if you exsanguinate, your time to death is only 5 minutes from having lost your vital signs. You're unresuscitatable after that time. So it's very short. And that's different to a different group of patients, the tamponade patients, which are usually when you've got a penetrating injury to the heart, usually by a bladed instrument or a firearm, occasionally from broken ribs from blunt trauma. Then you have a little bit longer. You've got up to 15 minutes in that scenario. So they may not have been aware of this when they attempted resuscitation. We also know that the time from your arrest to also the changes in your heartbeat are also quite clearly mapped in these patients. And in exsanguinating patients, you progress to asystole much more quickly than you do in tamponade. And the presence of organized electrical activity should be seen as a positive prognostic sign and something that you need to look for if you're going to go ahead and do a thoracotomy. At 24 minutes then, so just 2 minutes, which is the time that we're looking to do the thoracotomy in. It shouldn't be any more than that, and a well-trained team should be able to deliver that quickly. They've opened the chest, as you can see here, with a clamshell incision. So they've made 2 thoracostomies. They've joined those thoracostomies with a big incision across the chest of the nipples. They've cut through the intercostal muscle. They've divided the sternum, usually just with some tough cut shears and some strong hands. They've got access to the heart, having spread the sternum apart with the fasciitos. And then they've opened up the pericardium to expose the heart and give them access to repairing any wounds that might be there, which there aren't. And they've stuck a hand on the aorta. Sticking your hand on the aorta is a really important intervention, particularly for distal trauma. You are stopping any further blood going down to that area where the blood's leaking from. But really importantly also, you're helping to resuscitate the heart. By sticking the hand on the aorta, you're increasing the afterload that's there on the heart, which helps to perfuse the coronaries, which helps to resuscitate the heart. And a big problem of hypovolemic arrest is not just that you've lost all that volume, it's that even when you replace the volume, the heart is suffering and has been ischemic for quite some time, and then it doesn't work very well, and you have a degree of cardiogenic shock. So it's really important to think about cardiac resuscitation as part of treating bleeding. So they do that. In spite of this, though, they're going to spend the next 15 minutes trying to treat Danny and resuscitate him without any luck. As I said, he's outside of that survivable window. He's bled to death. In spite of everyone doing the right things, trying to get to hospital quickly, knowing the evidence about when they need to stay and play or scoop and run, he's going to have a poor outcome. At the same time, in South London, the HEMS team is chatting to Idris and asking him how he is, and he gives a thumbs up. His brain is working again. They're winning. His resuscitation has worked and is now perfusing again. And ultimately, he's going to survive. And 5 days later, having had some surgery to repair the wound to his artery, he goes home completely neurologically intact and well. So what can we learn from these 2 cases? These are essentially almost identical injuries that have happened at the same time, the same distance from hospital, similar patients with the same sort of physiological reserve. Well, I guess the first thing to say is success and failure can be measured in minutes and in millimeters in these cases. So the minutes that were taken for Danny to get definitive medical care of essentially taking him outside that window of survival. The fact that police were called instead of an ambulance cost him 2 minutes until they came and temporized his bleeding. The fact that an IO and some attempt at fluid transfusion was done before just scooping and running and taking him to hospital, again, cost him some minutes and took him outside of that window. And millimeters too. So in Danny's case, unfortunately, the wound looked to be in a similar situation to Idris's, but the track to that knife, and that's often the case that we don't know where the tip of the blade has ended up from the external wound, has transected his iliac artery. An iliac artery hemorrhage is torrential, but it's also usually non-compressible. So you can stick something on the outside, you can put your hand on it, you can put a tourniquet on, but the bleeding is usually retroperitoneal. The artery retracts, having been completely transected, and goes back beyond the pelvic brim. And there's nothing that you can do to stop it from bleeding, short of doing a thoracotomy or a BOA to get central access and control. And unless you understand the anatomy and physiology of these kind of injuries, you will continue to make those mistakes and we'll continue to see people die in the absence of having people that can deal with it. So what are we to do? If we said that scoop and run doesn't work for these patients necessarily, we said that stay and play doesn't work for all of them. Well, what we're trying to do at the moment is somewhere in between, a third way, which is scoop and play. And the idea being that we're doing the absolute minimum necessary for the patients and then trying to do it on the move. So this is kind of damage control resuscitation or hybrid resuscitation. But this has its own risks. Again, for those of you that have been in the back of ambulance, it's not very easy to cannulate people in the back of a moving ambulance. It's even less easy to go stick in a central line in the back of a moving ambulance. And it's dangerous. Having sharp sat in the back and surfing in the back of an ambulance is not very fun. And there's at least 1 serious accident involving an ambulance every week in the UK. So we're taking risk when we're standing up in the back of an ambulance and doing this whilst trying to deliver the absolute best care for our patients. But this is right at the cutting edge now. We're really trying to push the margins of what's achievable and what's safe. Maybe there's a better way. Maybe we can stop people from getting stabbed in the first place. And this comes back to a bit of what we were talking about earlier. There's a whole gamut of interventions out there that are being used and deployed in the UK to try and stop people from being the victims of knife crime. And they relatively go from carrot to stick. We're trying social and public health interventions. So it's really important. I'd say deprivation is a huge part of this, both for risk factors for people becoming involved as victims or perpetrators of knife violence, or being involved with gangs or drugs, which are obviously common causes of people being involved with knife crime. There are violence reduction schemes and units, the most famous of which is in Glasgow, which has been incredibly successful in reducing the number of stabbing victims there and reducing violence in general. There are things like legislation which seem easy, but when crimes like that committed by Axel Ruda Cabana are perpetrated by him being able to get a knife from Amazon without ID checks, you can see how actually if we can put some simple things into place, we might reduce the number of victims that we have. So age limits and ID checks are important. There's things like intelligence-led policing. So the case I talked to you earlier about with Paul Villamy and the work around schools, well, one of the things that was done to try and reduce stabbings was to stagger school times. So there was stagger school exit times in local areas by 15 or 20 minutes. And they'd also put police at key junctions where schools came together. So different rival gangs or groups would come together. They'd have police strategically placed around there. And again, I've seen a reduction in the number of altercations and serious incidents that will happen as a result of that. So that's something smart that we can do on the back of research, which is why research is important. And there's stop and search. So obviously much less palatable, and it's got a very bad press and much more towards the stick end. We can target individual groups who are likely to be carrying knives. And that's very controversial in the UK, perhaps not so much in other parts of the world, but it is here. And there's tougher sentencing. So again, to act as a deterrent to people carrying knives and using knives, we can have tougher sentencing, but that tends to end up just with more people in prison. And again, not something that's palatable necessarily for society. We've said the effects as well of knife crime are very difficult to treat. Death from exsanguination happens really quickly. Many patients will die within 15 minutes from the time of injury, and there's nothing we can do about that, short of trying to provide better care and faster care. And we'll talk about how we might do that. And it's a constant struggle with the inequity of resources and the geography that makes the medical response a challenge. We said that for London, for example, a daytime population of 10 million, there may be only one HEMS team in that whole area to look after them, which makes you think. So what can we do? So other than being better, faster, be more of us, where else can we look? Well, I hope that you're familiar with some of these things, but I think this is the next frontier really in trauma care. It's not more doctors and helicopters. It's everyone else becoming armed essentially in the fight against trauma. And you may be aware of Good Sam, which is a responder app, which initially was used for CPR. So you'd be activated if you were nearby somebody who was in cardiac arrest to go and provide bystander CPR and first aid. There are things and programs like Citizen Aid, which again become a bit more in the public domain since things like Manchester, which are teaching people how to provide direct trauma care, to improvise tourniquets, how to compress hemorrhage so that you can be that person on the spot who provides care, and that's incredibly important. We're getting a lot more help from our colleagues in the police and fire service. So levels of first aid training are much better and higher, especially the police tactical medics are incredible. They're absolutely brilliant at providing care to people who have been stabbed and shot, and again, performing life-saving intervention. One of the things that's been done in London before is having the fire service co-respond to Cat 1 calls, so the most serious calls. And if they get there first, they will provide the CPR, they'll provide hemorrhage control, because they recognise the ambulances can't always be there first time, particularly given the challenges on the ambulance service and with hospital waiting times and A&E waits as they are. So that's difficult. And the last of these things is Your Stance, which you can see in the middle, and other organisations like that, which are providing peer support and training to people. So they're going into schools, into young offenders institutes and into prisons and teaching people at risk of being perpetrators and victims of knife crime how to provide support and first aid to people that are the victims of knife crime, which I think is pretty smart. And I think we'll need to do a lot more of this if we want to see more survivors from this terrible disease. So in conclusion, we really need a public health approach, I think, to knife crime. Bystander aid is the future. The more people that we can keep alive and with better physiology at the time that they're seen by the first healthcare professional, the better. And I think for healthcare professionals, understanding the physiology and the pathology of the disease is really important, because until you do, there will be cases that you'll miss, and there will be cases that we treat inappropriately. And I think fundamental to that is understanding the anatomy. As I said, it could be millimeters that make the difference between life and death, unfortunately, in this disease. And we need to work really quickly. So thanks very much for your time. Again, there's some references for the talk and some further reading contained on this QR code if you want to scan that. Some good stuff to read, a bit of light bedtime reading now, maybe. And if there's any questions, I can take some questions from the audience now.
Thank you so much, Johnny. That was fantastic. I'll get you no, you can see you're doing it, you'll stop sharing. Do put your cameras on if you're able to, because it's nice to be able to see a sea of faces rather than a sea of names necessarily. Quick question there from Joe, which was just confirming, was TXA used?
Yes, obviously. So I think TXA is really important, and we know from CRASH 2 and the subsequent CRASH trials that on a population level, giving TXA to trauma patients that are bleeding saves lives. So it's really important. What I would say is it's not going to stop people bleeding from arterial hemorrhage. So the priority always has to be to stop the bleeding. And I would take TXA away from your initial thinking and your resuscitation of those patients. It should be something that you're doing on the ambulance in the way to hospital rather than prior to getting any bleeding control. So yes, it's incredibly important, but not so much as all the other basic things we're doing: direct pressure, tourniquet application, bandages, and central control. It won't stop, unfortunately, large vessel arterial hemorrhage.
Cool. So there's a question here from Robbie who says, "Hi Johnny, you mentioned damage control resus. How has the adoption of damage control resuscitation, such as permissive hypertension and whole blood transfusion, changed pre-hospital trauma care? And what are the challenges in implementing these strategies in civilian pre-hospital teams, those with HEMS capability and those that do not?"
Oh gosh, that's a big question. I feel like that's one for the pub. I think, yeah, no, thanks. That is a good question. I think we are learning all the time that we understand very little about this disease, and we go through cycles in medicine of adopting new ways of working, which can only really be backed up with evidence to decide whether they do work. I think papers that have come out like today from the LAA group with thoracotomy will change practice in terms of who we deploy those techniques to, who gets a thoracotomy, and we are still waiting, unfortunately, for a lot of the evidence for other things that we think are useful and reasonable, things like giving blood transfusions. We thought that Reboa might be the answer, and we still think, many of us, that it is the answer for some of the diseases that we see. But again, trials point the other direction. So we're finding our way, and a lot of this is experiential. I think we know that pre-hospital blood transfusion, even without the evidence, is valuable and keeps patients alive. We know that minimizing time to hospital is valuable and keeps patients alive. Proving some of those things are a bit more difficult. I think what we're trying to do is always strive for the best evidence and pulling bits out of military care where we can, because they've often been the leaders with this. Particular stuff from Afghanistan, I think, has been really valuable in driving this last 10 years of development. I can't tell you what the next 10 years looks like. If I ask the people at the Royal London, they might tell you it looks like ECMO for some of these patients that are really shocked. They might tell you again it looks like Reboa, which they're still deploying there, and we're starting to deploy in other pre-hospital services in the country. But yeah, this is too big a question for me to answer here. So I say I'll find you in the pub sometime to have a chat about it.
And I think, the trauma that what we're learning from the military is so important, isn't it? That, the exposure and the amount of trauma they've had opportunity to try different things on, and the way we were able to be so reflexive in COVID, and to do the big trials for treatments in COVID. Well, the same way Army are able to try lots of different things during their time in Afghanistan. And I think there's still a lot of work to be published from there, isn't there?
Yeah.
I was going to ask you, Johnny, what are you most excited about coming out in the research? What are you waiting for, that maybe it's a trial that's going on or that needs to be done?
Well, I think the big thing, as I've already mentioned, is blood. I think that's going to make a big difference. There are still some services out there in the UK that don't carry blood. The majority do. Some are still carrying only red cells. Some have got a mixture of red cells and FFP. Others have got lyoplasm, freeze-dried plasma. I think we would all like to see a positive outcome for the SWIFT trial, which I think would just push care a little bit further forwards. Those of us that spent some time in pre-hospital care know or feel that we know that it's the right thing to be doing. And I think hemostatic resuscitation with a whole blood product is the grail, really. So if we could have some evidence for that supports it, because it's an expensive intervention and there's a lot of logistics around it, which makes it difficult to provide, I think that would really move care forwards, and you might see it becoming a bit more populous and even disseminated down into the ambulance service. I don't think there's a reason that critical care paramedics, for example, out there couldn't in the future be transfusing blood themselves. But we need the evidence, I think, to move that forward. So that's the big one, I think.
Super, thank you. There's a question from Billy, who works in the ambulance service. And he says, can you suggest the best management for an abdominal wound or hemorrhage? JR Calc, which is the guidance that guides what paramedics are able to do. For those who don't know that, suggests hemostatics, but other guidelines say not to use them.
Is this just in regards to packing an abdominal wound, or is this just in abdominal wounds in general? Because I think there's been some concern about things like C-LOCs coming into contact with lung tissue or bowel or other things, I think, which is, I think, part of the reason that it suggests not stuffing into open wounds.
You can put your mic on if you want to, Billy, or you can type.
Packing.
He said packing. He said packing.
Yeah. I think it's rare. It's not impossible. It's rare that you're going to get bleeding from an abdominal wound that is amenable to packing or is going to be temporized with packing. It's not saying it's the wrong thing to do. If you ever do get it, I absolutely would try put something in it to stop the bleeding. One of the concerns I think with abdominal wounds is that often if the hole is big enough, you will get some bowel or some momentum coming back out of that hole, and pressing on that wound can often cause a very profound vagal response from the patient, which can make them look very poorly, and in fact to make them very poorly. They can become very bradycardic and hypotensive at a time that they're already not very well. So you can make things worse. As I say, there aren't very many big arteries and other things in the skin and the abdominal wall which are going to cause significant hemorrhage. So I think if you're unsure, and particularly if there's anything coming out of the wound, I wouldn't try stuff anything back in it because you're likely to cause a vagal response. I would use something like a blast bandage. There's in fact a little plastic bit that comes in the blast bandage and in the earliest, which you can take out and you can put over bowel or anything that's come back out of that wound, and then you can wrap it with a blast bandage and just apply some gentle pressure. And I think that's the most that I would do. But I would never say never. I'm sure there's been a time that I've gone and stuffed some C-LOCs or something into a hole somewhere because it's been bleeding too much. And ultimately, if you feel the bleeding is a major problem, and particularly that bleeding is external, then I would do what you need to do to stop the bleeding. I don't know whether that is even an answer, but that's my best guess.
Thank you. That's great. So there's one here from Colin. It says, a quick question about the initial pre-hospital care we can provide, and specifically junctional penetrating trauma. There was a study and information around the use of Foley catheters in penetrating neck trauma, with a study by Scruber et al. Showing it to be very effective in that specifically. Has this been explored in penetrating junctional trauma that borders the neck?
Yeah, so that's absolutely one of the things in your arsenal. Obviously, as we said, the wound externally does not often correlate with what you're going to find inside, and that's definitely the case in the neck, in that you can have major vessel bleeding even from a small wound, and you actually can't compress over the site of where the bleeding is. So using a Foley, or we've used ET tubes previously with other kind of junctional wounds when you need something a bit bigger, can provide some indirect pressure, so internally. There are risks to that though. So you stick something in the neck, you risk dislodging any clot that's already been formed. So you might make the bleeding worse. You risk putting it into the vessel that's actually bleeding and extending the size of that wound and making the bleeding worse. And the other thing that's particularly prevalent in the neck is when you increase the pressure in the neck, again, you'll get a carotid sinus response from that. And again, you cause significant vagal stimulation. So you can make your patients bradycardic and hypertensive. And I've even seen patients arrest from that before. So you have to be very careful. The other thing with stopping any bleeding from the neck is that as soon as you close the system and there's active bleeding, then hematoma can develop, and that can then cause deformity to your midline structures. You can get quite rapid airway compromise. One of the things that you do when you see a thyroidectomy patient who comes in and they can't breathe or they've got bleeding is you pull all the stitches out to let that blood out, because the bigger threat is to their airway. So yes, it's something that you certainly can do if you can't control the bleeding, but there are risks to it. And I think that needs to be a balanced decision, and generally one that I'd kind of leave with often the doctor level of stuff, because we maybe carry the can for making some of these slightly more dodgy decisions pre-hospitally than if you're in the paramedic profession.
There's a slightly different scope, isn't there? You know, we can get away with trying things sometimes, which it's harder for people with different registrations, and it's not fair, but it's just the system at the moment.
Yeah.
Jerome's asking, could blood transfusion pre-hospitally have made a difference for patient one? So I assume he means Danny?
Yeah, so it
Maybe.
certainly would. Sorry, go on.
Oh, and then he was also asking, do pre-hospital teams in London always have POCUS? But I guess, yeah, that wider, do most pre-hospital teams in the UK have POCUS or not, if you know?
Yeah, so on the first point, it's on the blood. Yes, giving blood would absolutely have been helpful for that patient. The problem, as we said, is that the blood needs to go in quicker than it's coming out, and that's one of the really big challenges if you can't get central vascular access. So we said those patients are shut down, they're very difficult to cannulate. If you can't get good proximal IV access, you're never going to win with IO. So I love IO. It's got me out of some holes before, but it's good for patients that are not actively bleeding. It's great for your cardiac arrest patients where your priority is pushing drugs and your CPR and your defibrillation. Patients that are exsanguinating, you will never catch up. And it's a fool's errand if you think that you are making the patient better by doing that. You're probably just taking too much time. So the key is central access, really, or proximal access, and that's where, unfortunately, it is about availability of the specialist skills to provide that. That's still mostly a doctor-based skill in terms of getting central access for patients. In terms of POCUS, which might give you an option to find a vein that's hiding deep down there somewhere, then that is a thing that's coming back into paramedic practice. Certainly in London, the advanced paramedic practitioners all carry ultrasound, mostly for around their cardiac arrest management, but can obviously be used for other things too, which might help you find some access. I'd just direct you all again towards the external jugular. If you haven't had a play down there before and had a look, maybe size up your next patient to see what it looks like, because that again will get you out of trouble sometimes if there's nowhere else. And it's as good as you're going to get as central access in many cases with a peripheral cannula. So something to have a chat about with your whoever you train with, and if you're taking patients into hospital, have a discussion with your receiving team about that. But that's always an option for you. But yeah, certainly blood, I think, would have been very helpful for that patient, would have been one of the few things that would have bought you a little bit more time.
I mean, the challenge can be getting the blood in quickly, as you say, and if you're using reconstituted or if you're using whole blood and what's being carried as well, isn't it? Because not everybody's carrying whole blood at all,
Yeah,
or
so
packed red cells.
yeah, so all the logistics of checking, spiking, squeezing, all of that stuff takes time. Putting blood through a warmer, which should always advise that you do. We should always be giving blood warmed whenever possible. We'll also limit your flow rate. So most warmers, you're only going to get between 150 and 200 mils a minute through there. And again, if the hole is bigger than that and it's coming out more quickly, you're still losing. You could be as busy as you like, but you're still losing. So it really is about hemorrhage control, and that's where absolutely nailing the basics of direct pressure, junctional, when sticking your knee in that groin, getting your packing right with your C-locks, using tourniquets, doubling up on your tourniquets if you don't feel you've got adequate compression, and ultimately central vascular control of the aorta with Reboa or with a thoracotomy.
I don't know, Jerome, you're one of our students. I don't know if you're doing 8A or 8B for your options, but the pre-hospital one, which 8A, we have a great simulation, which we filmed with the air ambulance Kent, Surrey and Sussex, with and it's an amputation, traumatic amputation, and it's bleeding, and we can see how long it takes to even just try and get the blood in and get things going on the scene. And it's quite scary about how that length of time, and you're sitting there watching it going, just give it. But it's actually a big pause, isn't it, Johnny? It does take. It's not just whack it up, like it's not like when we're in hospital and it's sitting behind us in a fridge and everybody's had the heaters ready to go for hours and you can just throw it in.
Yeah, unfortunately not. It's a big thing, and the decision to do it, and it's particularly to do it when you're not moving towards hospital, is a big one, and you can come to rue those decisions for some of these patients. Yes, so challenging, and yeah, obviously something that we're still trying to get better at.
Brilliant. I'm going to wrap it up there, but thank you so much, Johnny, for your time tonight. I'm sorry that Harriet's sick in bed with pneumonia, but you did a fantastic job, and I certainly found that absolutely fascinating to think about those two cases in parallel and what was happening across them all. And I think hopefully lots of other people on the call got lots out of it, which is fantastic. So if you've got we'll post that for anybody else who wants to watch it again. I put the links into the chat if you didn't see it for the link for the new paper that came out today, and also for the Google Drive, which has got all the references and things like that in there. If anybody's interested in our MSc and is not already on it or signed up for it and wants to find out more, David's just posted a couple of links there for the emergency and resuscitation medicine and for the pediatric emergency medicine. My contact details are on that site. You can contact us if you want to find out more about it, or if you want us to come and talk to you or to your teams or anything else like that. But other than that, it is a Thursday night. I know Johnny's had a long day of work and children, and thank you for giving up your time tonight. A virtual round of applause from everybody, and have a good evening. Thank you everyone for coming.
Cool. Thanks very much, everyone. Thanks for your time. Take care.